Good afternoon and welcome to our Neuroscience lecture series. I am Dr. Rogelio Rivas, Corporate Vice President of Baptist Health International. It's my pleasure to welcome all of you to this informative presentation. I would like to extend warm greetings to our friends across Latin America, the Caribbean, and everybody joining us today. During this interactive presentation, you will have the ability to ask questions via the Q&A feature located at the bottom of your screen. I will also be your moderator for today's lecture. This afternoon, I have the pleasure of introducing Dr. Richard Morgan. His presentation is titled Cervical Spondylotic Myelopathy, Current Diagnostic and Treatment Strategies. Dr. Morgan is a spine physician at Baptist Health Miami Neuroscience Institute, specializing in physical medicine and rehabilitation. As a physiatrist, Dr. Morgan focuses on providing physical medicine rehabilitation interventions that help patients regain function and mobility. His clinical research and research interests include diagnostic and interventional neuromuscular ultrasound, spasticity management, and regenerative medicine. Dr. Morgan earned his osteopathic medicine degree from Nova Southeastern University in Florida and completed his physical medicine and rehabilitation residency at Larkin Community Hospital. Dr. Morgan has been published in multiple medical journals, including the Journal of Brachial Plexus and Peripheral Nerve Injury. He has also presented extensively at national medical meetings. He is a member of the American Osteopathic College of Physical Medicine and Rehabilitation, the American Academy of Physical Medicine and Rehabilitation, the Association of Academic Physiatrists, and North American Spine Society. Please, let's give a warm welcome to Dr. Richard Morgan. Doctor?
Hello, I'm Richard Morgan. Thanks for the introduction and thanks for having me speak to everyone today. My topic is going to be on cervical myelopathy, as mentioned before. I have no financial interest or relationships to disclose here. So some of the points that we're going to discuss today are the history and physical exam, diagnostic imaging, treatment and management approaches. And I included one case, that way we could bring everything together in a more clinical, relevant as an example. All right, cervical myelopathy. Start off with the background. It's cervical spondylotic myelopathy. It's the most common cause of myelopathy in adults over 55 years of age. So in younger patients, this may be attributed to a disc herniation, which could occur after a traumatic incident. But in older adults, especially over 55 years of age, it's usually caused by degenerative changes and spondylotic changes. Approximately 5 to 10% of patients.
Dr. Morgan, sorry to interrupt. I don't see the slides.
Oh, you don't? Okay.
No.
Sorry. Go. All right. Can you see it now? Sorry.
We're good.
All right. So let's, I'm going to fast forward and pick up where we left off. So about 5 to 10% of patients who have cervical spondylosis will develop myelopathy. There's a poor prognosis if these symptoms have been present for greater than 18 months, and it is recommended typically to proceed with surgical intervention after 6 months of symptomatic onset. The most commonly involved levels are C5 to C7, and that's in cervical spondylotic myelopathy. This is different for, what we would see in younger patients where cervical spondylosis isn't coming into play. And typically in cervical spondylotic myelopathy, we'll see lower motor neuron findings at the level of the injury. And at the levels below, we'll see upper motor neuron findings. And I'll go into that in a little bit more detail in the forthcoming slides. So include a few examples of some of the symptoms that a patient may describe during the clinical visit. Typically there's neck pain. It'll radiate out to the scapular region and shoulders, and to the arms as well, and to the fingers at times. There's numbness and tinglings in the arms and hands bilaterally. Sometimes this can also involve the lower extremities and the feet as well. Loss of hand dexterity is commonly described in these patients as well. So hand coordination, dropping objects like a fork or a pencil are some of the examples that a patient may describe as well. And this is more for the exam, but patients may describe some gait abnormalities, loss of balance, trouble walking, and at times they may mention falls. And so on the exam, we'll see a spastic scissoring gaits where you'll notice that the lower extremities kind of cross midline when walking. We'll notice loss of vibratory sense and proprioception in the upper and lower extremities. So typically that could be tested with a tuning fork, but a patient may describe numbness and tingling, as I mentioned before. Weakness in the upper extremities and lower extremities. And one red flag symptom that patients will commonly describe with cervical spondylotic myelopathy is bowel and bladder dysfunction. So in these cases, it's usually urgent incontinence where they have a sudden emergency or urge to go to the restroom and they don't make it. So that's something that would be alarming to the patient, but at times you may have to elicit that from the patient and try to get them to describe that in further detail, because that's at times that's not something that somebody will offer to discuss right off the bat. And so as I mentioned before, a lot of the key findings on exam are going to be upper motor neuron findings. So that would include brisk reflexes. At the level of the injury, you may see decreased or diminished reflexes. So as an example, if it's a C5 cervical spondylotic myelopathy, you may see decreased biceps reflexes, and within the brachioradialis, triceps, and even the lower extremities, you'll see brisk reflexes. Positive Hoffman sign is another key indicator of upper motor neuron injury or cervical spondylotic myelopathy. So when you flick the middle finger, you'll see the thumb approximate the index finger, and it'll make a pinching movement. Pronator drift is when you have the patient have the palms up in both hands. And after a few moments, you'll notice that one hand is kind of drifting off to the side and turning in pronation. Crossed adductor and crossed extensor reflex. When you're checking the reflexes in the lower extremities, and this is typically tested with the patient lying supine, you'll see the opposite leg either move into adduction or extension when you're testing the opposite reflex. Upgoing Babinski response, sustained ankylosing, and positive Romberg test. Those are all also indicators of upper motor neuron injury and cervical spondylotic myelopathy as well. And so I included this to just define some of the symptoms and the exam findings that we'll notice at different levels throughout the cervical and upper thoracic spine. So as I mentioned before, in cervical spondylotic myelopathy, at the level of the injury, you'll see lower motor neuron findings, and the levels below, you'll see upper motor neuron findings. And the example I used before is a C5 spondylotic myelopathy, where the biceps reflexes are decreased, and the levels below that you'll notice brisk reflexes. This becomes a little bit tricky because there's often concomitant radiculopathies at various levels, and it's also common to see peripheral neuropathies or carpal tunnel syndrome, cubital tunnel syndrome, more distally in the upper extremities. So that's really when a detailed exam pays off, when you can kind of delineate what exactly is going on. And at times this will require a nerve conduction study and further examination with other diagnostic testing, which I'll go into and forthcoming slides as well. So these are some of the differential diagnoses. I included this. The differential diagnosis is pretty wide, but these are some of the ones that I noticed through all the literature that I reviewed prior to making this PowerPoint. So ALS, Guillain-Barré, syringomyelia, central cord syndrome, Chiari malformation, and multiple sclerosis. Those are some of the differential diagnoses to take into consideration. So I think this slide is very important and something to take into consideration when initiating a workup for a patient who has suspected cervical spondylotic myelopathy. So this will require a cervical spine MRI, usually a starting point for this. Typically, we'll start off with cervical spine MRI without contrast. And this has been shown to be just as sensitive and specific as an MRI with and without contrast. So as I mentioned before, 33 to 50% of patients will have greater than one level involved. And in patients with cervical spondylotic myelopathy, that's going to be most commonly between C5 and C7. Now, the most important factor to consider when reviewing an MRI are the T2 signal intensity changes. So the hyperintensity lesion within the spinal cord when looking at the MRI. So this can be an indicator of severity as well. And so these patients who have the T2 signal hyperintensities in a lot of cases have poor recovery and more severe motor findings and symptoms as well. One of the emerging imaging studies that can also be considered is diffusion tensor tractography. Has a greater sensitivity than T2 weighted images on MRI. But I think this the utility of this study is limited just primarily because of the cost of this study. So with tractography, we're able to look at the actual nerve fibers within the spinal cord in much finer detail, and we can see the extent of injury in much more detail with that study as well. So in this image, we can see the example of the T2 hyperintensity. So typically when I'm evaluating a cervical spine MRI, I start off with the dens all the way up here, the triangle-shaped vertebra at the top. That's C2, C3, C4, and between C4 and 5, you see this hyperintensity, which is where the arrow is pointed right there. Okay, so I included this case that way everything kind of come together and make more sense in a clinical point of view here. So I included the case of, and this is a case that I created. This is not a real case, but this is something that this is a kind of common clinical presentation that we see in clinic. So the 49-year-old male, right-handed male, he comes in with acute on chronic neck pain relating to bilateral shoulder blade, worse on the left compared to the right. He has been experiencing upper and lower extremity numbness and tingling, subjective weakness in the upper extremity on both sides, difficulty with grip strength. He's having trouble opening jars and is dropping pens and utensils as well. He mentions that when he walks, he feels like he's tipping over to the side, and he feels like he almost falls over, but has not actually fallen over to this point. He also mentions that he's had some incidents where he has a sudden urge to go to the restroom and he doesn't make it. So he has incontinence. And he's describing urge incontinence, which is an upper motor neuron form of the incontinence. So he's been involved in 2 motor vehicle accidents in the past, no surgeries in the past, works as a truck driver. He's undergone physical therapy in the past, multiple epidural steroid injections that really has diminishing returns and aren't really working for him to this point. On the exam, so he has really significant limited range of motion in all planes in the cervical spine. Now, this is where the clinical exam can really help delineate a cervical myelopathy as well. So motor testing, we noticed that he has 4 out of 5 wrist extension on the right side. So that's C6, wrist extension C6. 4+ out of 5 biceps flexion on both sides. That's C5. And then decreased grip strength and 4+ out of 5 finger abduction, adduction, bilateral. That's C8, T1 level. So the way that we test for sensory deficits in our clinic is with a neurotip. So we check pinprick, dull sensation, and at times, if indicated, vibratory sense with a tuning fork. So on the exam, this patient had decreased sensory response to pinprick in the right C6 and bilateral C5 dermatomes, and deep tendon reflexes. Once again, at C5, diminished reflexes. Right brachioradialis, diminished reflex, which is C6. Below that level, he has brisk reflexes all the way down to the Achilles. So based on this exam alone, this is kind of indicating an injury level at C5 and C6 with upper motor neuron findings below. And so this exam finding alone would lead you to suspect a possible myelopathy. Additional testing, positive Lhermitte sign. You bend the neck into flexion and they have electrical shooting all the way down the spine. Positive Hoffman's test bilaterally, upgoing Babinski on both sides, sustained ankle clonus on both sides, and positive cross adductor reflex and positive Romberg test. A lot of these are upper motor neuron findings. These also support a possible diagnosis of cervical myelopathy. So in this patient, some of the exam findings some of the diagnostic tests that we would start off with is a cervical spine MRI without contrast, cervical spine X-ray with flexion and extension views. That way we could look for any instability with one segment in relation to the rest of the unit when bending forward or backwards. If there is instability, that's something that can contribute to a myelopathy or cord compression. And a nerve conduction study of the upper extremity. And in a lot of these cases, we see concomitant cervical radiculopathy or carpal tunnel syndrome or cubital tunnel syndrome. There is a theory that a proximal nerve injury will lead nerves more distally prone to injury as well if there's compression more distally. This is called the double crush theory. So, it's something to take into consideration as well. Also, a nerve conduction study is important to complete in these patients as well, because there is a chance that this patient's pain is attributed to cervical spondylosis or axial neck pain with carpal tunnel or cubital tunnel syndrome in both hands, which could mimic a cervical myelopathy. So you want to make sure that you can rule out carpal tunnel syndrome, cubital tunnel syndrome, and a cervical radiculopathy before you do a neurosurgery referral. That way you're kind of preventing any unnecessary surgeries or more aggressive interventions there. And this is where the team aspect comes into play too. So I'm a non-surgical spine physician, and so I do a lot of the more conservative treatments, but I also do a lot of the electrodiagnostic testing and ultrasonography in our clinic as well. So I see a lot of patients who have cervical myelopathy, but also symptoms that mimic a cervical myelopathy, and we're able to rule out and prevent potential unnecessary neurosurgical intervention through EMG, nerve conduction studies, and these other diagnostic testing. Okay, and so this is another example of cord compression, and these images correspond with the patient that I was just going over right before this slide. So this patient, we see a few levels of cord compression or T2 signal hyperintensity changes within the spinal cord. So starting from the top, that's C2, 3, 4, 5, 5, 6, and then 6, 7. Right here within the cord, you can see this white hyperintense area, and that's cord compression. And image B on the right-hand side, you can see also this flattening along the ventral aspect of the spinal cord. And on the right-hand side of the actual spine, you can see there's those hyperintense changes as well, right where this arrow is pointing to. Okay, and so this is an example of a cervical spine flexion and extension X-ray. In this case, this patient doesn't have any instability, but that's what these images would look like. Patient in neutral in the middle, and then an extension on the left side, and then inflection on the right side. If there was instability, we would see one of these segments move anteriorly or posteriorly with flexion or extension. And so management of this patient with multiple upper motor neuron findings, red flag symptoms, and T2 hyperintensity changes within the spinal cord. This will be a referral to neurosurgery. And we would discuss this over with our neurosurgeons here. And one of the most commonly performed procedures for this is a C5, 6, and C6, 7 ACDF, which is what this patient would have to undergo in this case. So some of the clinical pearls or takeaways that I like to mention before we wrap this up here is that about 80% of patients with cervical spondylotic myelopathy will present with numbness and tingling and other sensory deficits within the hands upon initial evaluation in the clinic. So that's a very common complaint of these patients. Surgery is considered when there is progression of symptoms. In the case that I just went over, this patient had pretty profound red flag symptoms like incontinence, gait disturbances, loss of hand dexterity. So those are patients that symptoms that you would want to prevent progression of, and also prevent from becoming irreversible at that point too, if they've been going on for a long time. That being said, if a patient has some of these symptoms for greater than 6 months, that should indicate a neurosurgical evaluation too. The compression ratio is another thing to take in consideration. Usually that's something that will be evaluated by a radiologist, and they'll mention in the report. But you would want to evaluate the sagittal and transverse measurements, and this should be within less than 0.4 if there is cord compression. You'd also see the formation or the shape of the spinal cord, and it will look like it's being flattened and not as its circular form. And the timeliness of surgical intervention is critical with these patients, because you want to prevent some of these symptoms from progressing and becoming irreversible. And patients who have had these symptoms for greater than 6 months tend to have less optimal outcomes, even if surgery is performed at that point, than patients who undergo surgery prior to 6 months of these symptoms. and some other considerations. Patients who have poor response to surgery, older age, or greater frailty when they are presenting or when they undergo the surgical intervention, which typically the ACDF, as I mentioned. Patients who have the T2 cord signal hyperintensity changes typically commonly have poor outcomes as well. There's greater disability at the time of the surgical intervention. Those patients are less likely to see greater recovery and outcomes than patients who don't. Longer duration of symptoms. This is greater than 6 months. Patients who have greater than 6 months of symptoms tend to have poorer outcomes as well. Patients who have smaller central canal diameter. This could be patients who have congenitally narrow canals as well, because there's just not that much or enough adequate space within the canal. And if there's multiple levels involved, these patients typically have poor outcomes as well. So in our clinic, we communicate frequently with our neurosurgeons, with our interventional pain physicians as well. And so in my case, it's nice having that communication because I could perform an EMG nerve conduction study. We could rule out a carpal tunnel syndrome, radiculopathy, and cubital tunnel syndrome, and narrow down the diagnosis to a myelopathy alone. And then we have our neurosurgeons right down the hall we could refer these patients to. And a lot of times they could see them within the same week, or if not, a week later. So we could really get on top of this quickly before these symptoms progress and become irreversible. So that's one of the benefits of having everybody underneath one roof and having open communication and dialogue with other specialists within the Neuroscience Institute. So yeah, that concludes my presentation. I hope that that kind of clarified some of the questions with regards to cervical myelopathy and was helpful. So thanks for having me speak today, and I'll open the floor to any questions.
Thank you, Dr. Morgan. That was fantastic. I have a quick question. I think that team approach has really helped you all get the gold standard ranked. Your Neuro Institute has been ranked gold in the U.S. News and World Report, and congratulations on you and your team on that ranking. The weakness in tingling that you were talking about, does it come and go, or are you looking for persistent? Or talk to me a little bit about that symptomology.
That's typically persistent in patients with cervical spondylotic myelopathy. Patients who have carpal tunnel syndrome, typically that tingling and heaviness in their hands will wake them up at night. So that's one way to kind of differentiate between the two. Typically carpal tunnel syndrome, especially in mild and moderate cases, though those paresthesias of the numbness tingling are going to be intermittent and less likely to be persistent. But in these patients, it's more likely to be persistent. And so that's one way to differentiate. And then going a little bit further, we're going to assess that a little bit more with a nerve conduction study in EMG. And I can really get down to the bottom as to what's causing those symptoms as well.
Thank you. And we have a question from Dr. David Barnett from the Bahamas, orthopedic surgeon. Dr. Barnett asks, please comment on why C5, C7 is most commonly affected and what your experience is.
That's a very good question. I don't have an answer for that. I think that's just what the research was able to identify as the most common cause. I think most likely because the thoracic spine is less mobile than the cervical spine. And once you start to get around C7 and T1, you kind of reach that juncture where cervical spine is hypermobile. Well, it's much more mobile than thoracic spine. And so you kind of have that hinge effect where there's more motion in the cervical spine compared to the thoracic spine. So at that level, especially C7, T1, more likely to see more degenerative changes, disc changes as well. So I don't have a clear, straightforward answer, but that would be my theory as to why that area is more commonly involved.
We're going to call that the Dr. Morgan theory.
Yeah, there you go.
Okay,
Write a book on.
so you talked about the diffusion tensor tractography. Is that something that is easily performed elsewhere, or is that you said a little bit more costly? Talk to us a little bit about that.
We have access to that here at Baptist Hospital, and that's one of the more emerging technology. So, you'll see a lot more of that in the research, and that's a much more sensitive test than the cervical spine MRI. And so hopefully in the future, that's something that we'll be able to utilize a lot more, because that helps us identify specific nerve fibers within the spinal cord that are involved and that are injured. Whereas with an MRI, where it's more of a generalized image of the group of neurons within the spinal cord that are injured. And we see that with the T2 signal changes, as I mentioned. But with the DTT, we can really get down to single fibers within the spinal cord, which was pretty fascinating to see. But that will be a game changer if we could utilize that more in the future.
Thank you, doctor. And some places might have a T1. You know, some places are lucky enough to have a T3 MRI. Do you see any difference in your world, or do you prefer one or the other?
Yes, especially for when we're looking for T2 signal changes, the quality of the image is really important. So we're lucky to have excellent MRI machines here that are T3. And so because we have good quality machines here, we really don't have to use contrast with these patients, and you can visualize these T2 signal changes within the cord pretty clearly. And the more the lower quality MRIs, sometimes it's hard to visualize those T2 signal changes, and so in those cases, I would be more I would probably want to order with and without contrast. That way you could visualize those T2 signal changes a little bit better. But luckily here at Baptist, I mean, it makes our job easier when we could see these T2 signal changes in the injury to the spinal cord without contrast. And that's beneficial to the patient too. There's a lot of patients who have allergies as well. So, we do see major differences, especially with this specific condition with the quality of the MRIs.
And I think that whole team approach that you talked about, I think you all have also radiologists that are just trained into the neuro component, neural readings. And I remember how hard it is to find folks that are T3 emphasized, that a lot of artifacts and stuff. So you got to have a trained eye. Is that where you're seeing a lot?
And and I like to give an example of how the team approach is important and how we've been able to really take advantage of that here at Baptist. I had a patient who had Harrington rods placed when she was a child, and she came to my clinic. She's in her 50s at this point. She had seen a bunch of different specialists. There was no clear diagnosis. She had weakness, numbness, tingling in the legs. And on my exam, she was myelopathic. And so we got an MRI. It was difficult to see the spinal cord because of the Harrington rods and the metallic artifact. So I got a CT myelogram, and we were able to visualize a giant meningioma that she had compressing the spinal cord. That same day that the CT myelogram was completed, the neuroradiologist called me, as well as the neurosurgeon, Dr. Rothrock, that we have here, and we're lucky to have him. He's excellent. And so that was communicated to me. I communicated to the patient. Dr. Rothrock was aware. The patient went to the emergency department. the following day, she had the surgery and decompression of the spinal cord and removal of the Harrington rods. And when she first came to see me, she could barely walk. 3 weeks after the surgery, she was up and walking again. So I think that's a good case that exemplifies how the team approach really comes into play, especially in the Neuroscience Institute, where a lot of these diagnoses are very sensitive and can be irreversible if left untreated. And so I think we're pretty lucky to have an excellent team of radiologists, neurosurgeons, physiatrists, and interventional spine physicians here too. So it's much better for patient care.
In another lifetime, I worked at United Healthcare. And so looking at it on the insurance component, and insurance companies look at cost ratios, and certain employers look at getting people back to work or getting them back to be able to do what they do. How do you feel what you're doing now and the work that your team's doing at M&I helps out in the long term? We think about what's the long-term benefit for that patient or the long-term cost of a patient. How do you feel you all are affecting that?
Then we're really improving patient outcomes. We have we're starting up a wellness program here that identifies vitamin deficiencies, diet. It addresses exercises and just lifestyle modifications that could be made. And that's really where that's the foundation of improved long-term outcomes. At the same time, we have fantastic and interventional spine physicians here who could perform different pain procedures and provide these patients with more immediate pain relief as well. And so, we address immediate acute symptoms as well as long-term lifestyle modifications that both, when put together, that really improves patient outcomes and overall quality of life. And so I think we address every aspect of patient care, from preventative medicine, wellness, different lifestyle modifications, and preventing these irreversible neurological issues that could be solved with neurosurgery and other interventions as well. So I think it's a very well-rounded program here.
When I first started at Baptist Health International, I didn't have these gray hairs. But back in my day, I'm a GP by training. And so a lot of the folks that might be referring patients over might be from the general practice situation, might not have the ability of having access to neurosurgery doctor. What would you say if somebody, to be able to refer you a case, what are you looking for? I mean, I'm so happy to see how X-rays are still a component of life. As well as EMGs and NCSs, right? Yeah. But what would you like to, if Dr. Ribas is in another country, to refer you a case and to be able to present to you a case? What are the things that are the must-haves that you would need prior, to start up whatever workup you're going to do over here?
Well, the patient history, the symptoms that they're having, a very detailed history, detailed exam, that would be very helpful. And just some ideas as to what the possible diagnoses are. Here we can get an MRI fairly quickly. We can get a nerve conduction study fairly quickly if it is something that's emergent and needs to be addressed quickly. And so a lot of the diagnostic testing, we could do it here, and we could do it pretty rapidly. We have all the resources that we need. And so just a very thorough exam, the basics, the foundation of what the practice of medicine is, that's very helpful going into it, and just the thought process as to why the patient is being referred to us in the first place. That really helps us kind of prepare our mind as to what we should be looking for going into the clinic visit.
And percentages, like when you talk about patients that maybe you can delay a surgery or maybe you can prevent a surgery, right, and change them lifestyle, weight control, different things like that. Are we making a dent into that, being able to, a spine surgery, is that not every day, right, that people think about, but it is here, right? It is for you all. It's bread and butter. But talk to me a little bit about, how we're able to help out folks, and if we can either get them past, and maybe they might not need a surgery right away, maybe it just might be a disc or a situation like that.
Yeah, well, in these cases, in cervical spondylotic myelopathy, these are patients that should go to surgery sooner than later, especially within those first 6 months of having the red flag symptoms, as mentioned before. But um, especially in my practice, we exhaust all the conservative approaches, and so that could be different strengthening exercises, and even the non-conventional treatment approaches too, acupuncture, Tai Chi, Pilates, massage therapy. Those are all things that we address too. And as well as vitamin, supplementation, diet, exercise. And we make all these recommendations within our clinic. We even make customized, personalized exercise programs for each patient as well. And so we try to get these patients up and moving as much as possible, and we exhaust conservative management before we even consider surgical management. So, and if surgical management is needed, I mean, we're right down the hall from our neurosurgeons, and we have open communication, so that's fairly easy to address as well. So,
I know we're doing a lot of work with cancer care, and now we're doing a lot of work with neuro and cancer care and then being able to address something early, operate a vertebra, be able to fix that situation, and then the rehab that comes after. Can you talk to me a little bit about your involvement, or how, even helping those patients post surgery of maybe getting over a cancer or something like that, that's maybe non-metastatic or something like that?
yeah,
Uh,
so we address every aspect of lifestyle. So diet, exercise, and weight loss if needed as well, weight management. And so we know that keeping weight down, and I'll use an example of low back pain, keeping weight down, and core strengthening, and pelvic strengthening of the pelvic stabilizers that helps improve outcomes, especially after surgery, and helps prevent this from reoccurring pain and symptoms, radicular symptoms, especially. And so just addressing every aspect of lifestyle and well-being. And so we're able to do that. We speak with our physical therapists as well. We're working on that diet and that dietary program and the wellness program as well, which is just starting up. And so, yeah, we work with a physical therapist, wellness program. We have neurosurgeons, interventional spine physicians. So, yeah, we can address every aspect of patient care here. So,
Dr. McDermott would kill me if I didn't do a quick plug. That first picture you showed, can you talk to us about that new building?
so that's I'll go back to that in the PowerPoint. So that's a drawing that I found when it was first announced that we're gonna have a rehab building, rehab hospital, which will be built within the next 5 years, I think. So this initial sketch, it's beautiful, and it has I think it's planned to have about 80 beds with possibility of increasing size as well. So that's pretty exciting, and there's a lot of excitement around our program here. We have a new neuroscience building that'll be going up within the next couple of years as well, with outpatient clinics, physical therapy gym. So we're expanding. There's a lot of excitement around our program, and yeah, I'm happy to be here at this time, especially. And so there's a lot to look forward to here.
We have a question from uh, Dr. Hannah from Ruth Hannah from also from the Bahamas. And the question is do you see a role for chiropractic, or what's the involvement or plus or minus on the chiropractic side?
Yeah, well, I recommend chiropractic management for some of our patients, as long as they don't have any neurological findings or any significant let's say disc herniations or any major findings on the MRI. We've been able to identify some chiropractors within our community who really do excellent work. So I've become familiar with some of those names, and I typically refer to specific names within our community if that discussion comes up during the clinic visit. So I think there is a role for that. I'm also a DO, and so we do our own manipulative treatment as well. So it's different from chiropractic management, but we incorporate that into our patient care as well when needed and when the patient benefits from it. And so I've noticed with osteopathic manipulative treatment, there's really a lot of patients, especially with neck and back pain, who benefit from it, and they come back regularly because they notice major improvements after that's done. So I think there is a role for certain patients without major findings on MRI and without major neurological findings. And I've noticed a lot of patients, at least from my end, from the osteopathic treatments, that benefit from manipulative therapy as well. So I would just recommend become familiar with particular chiropractors, or if possible, if there are osteopathic doctors in the community, and really figure out who does excellent work and refer to those practitioners.
Thank you, Dr. Hanna, for that question. And with that, doctor, I think we've been able to navigate. I appreciate your help. And on behalf of Baptist Health International, I would like to thank Dr. Richard Morgan for his informative presentation and all of today's participants for your attendance. If you have any questions about today's presentations, please feel free to email them to us at BHIWebinars@baptisthealth.net. That is BHIWebinars@baptisthealth.net. Any questions we ask, we will get them over to Dr. Morgan and we'll get you a response. And we look forward to seeing all of you at our next Neuroscience lecture series scheduled for Wednesday, October 16th. Thank you again and have a great afternoon. Thank you, Dr. Morgan.
Thank you. Thanks for having me.
All right. Thank you.